Thank you, Chairman. It gives me great pleasure to present here in SAGES. Me and my co-workers, we don't have any conflicts of interest to declare, and also this study did not receive any external funding. So colonic resections are very common, and whenever we do anastomosis, there's always a concern for anastomotic leakage. Anastomotic leakage rate varies and depends on what type of anastomosis we're talking about. Taking ileocolic anastomosis, for example, the quoted leakage rate is about 0.5% to 8.7% in the literature. So much effort has been done in the past to study leakage and the ways that we can prevent it. For example, whether there's any advantage over for certain configurations or method of doing it, and how we can optimize our patients, etc. But very few studies focus on the ongoing improvement of stapling technology. One of these improvements is the triple row stapling device. With that, it has an additional row of staples, that is 3 staggered rows of staples on each side to seal tissue as compared to the conventional 2. So our study aims to study whether there is any difference between the 2 in terms of ileocolic anastomosis. So we got ethical approval, and then we include all our patients that underwent elective or emergency operations that involves ileocolic anastomosis, stapled ileocolic anastomosis, in 2 centers. So the exclusion are those with hands-on anastomosis. So the primary endpoint was anastomotic leakage and anastomotic bleeding. The secondary endpoints were intra-abdominal collections, reoperation rate, 30-day mortality rate, and length of stay. We generated propensity score for each of our cases, taking into the account their age, gender, ASA score, presence of various comorbidities, the serum biochemistry, history of cancers and previous abdominal surgery, type of pathologies, whether it's benign or malignant, the type of surgery, and the approach of surgery, as well as the stage of disease. Also, whether the patient have a perforated bowel or intestinal obstruction at the time of surgery. We compared the categorical variables of the chi-square test or the Fisher exact test. And for continuous variables, we use the Mann-Whitney unit test. In our centers, the functional end-to-end staple anastomosis was performed in a standardized manner. First of all, we made an enterotomy and colotomy for insertion of a stapler, and then we create side-to-side anastomosis at the anterior mesenteric border after the first firing of the stapler. And then the stapler is reloaded and was applied across the side-to-side anastomosis. With the second firing of the anastomosis, the specimen will be transected and the bowel will be closed. So altogether, we have about 860 patients with ileocolic anastomosis. After exclusion of those with hands-on anastomosis and laparoscopic intracorporeal anastomosis, we have about 560-odd patients with stapled functional end-to-end ileocolic anastomosis. About 300 patients were performed by the double-row staplers, and then 174 with the triple-row staplers. After propensity score matching, there were 170 cases chosen from each arm for comparison. So these few tables show the characteristics of our patients as well as the tumor and operative characteristics. Before the matching, the group with the double-row staplers have a higher incidence of chronic lung disease and a lower incidence of previous abdominal surgery. And for serum biochemistry, the group with the double-row staplers have a higher bilirubin level, as well as higher percentage of obstructing tumors and perforated tumors. Also, the tumors tend to be bigger and more advanced. And in the double row stapler group, the operations tends to be emergency surgeries and performed with the open approach. The estimated blood loss was also higher. So after the matching, we were able to have two groups which are comparable with all these parameters. So the results show that the anesthetic leakage rate is higher in the double row stapler group. Before the matching, it was significant, but after matching, the difference was not significant. For anesthetic bleeding, there was the rate of anesthetic bleeding was higher in the double row stapler group, but then the difference was not significant before and after matching. Similar for intra-abdominal collections, again, there was a higher incidence noted in the double row group, but then the difference was not significant before and after matching. The reoperation rate was higher in the double row stapler group, but the difference was only significant after the propensity score matching. The rate was 5.8% as compared to the triple row stapler with 1.8%. The 30-day mortality rate, as well as the length of stays, was comparable between the two groups before and after matching. The limitation of the study includes that firstly, this is a retrospective study, and despite rigorous matching, bias would still exist. And secondly, some of the clinical parameters like BMI could not be retrieved. And thirdly, we didn't take into account the surgeon's expertise. And we suspect that surgeons who have colorectal interest or even colorectal specialists are more likely to use the newer stapler. Also, the relatively low morbidity rate in this cohort requires a relatively large sample size, so that the non-significant difference observed here may be due to type 2 error. And lastly, this relatively low morbidity rate may not be able to generalize to other patient populations, given that it has a relatively low percentage of emergency surgeries and some conditions like inflammatory bowel disease, etc. So to conclude, the findings of this study show that there is a tendency of lower complication rate in anastomosis performed by the triple row staplers, but then the difference was not statistically significant. The implications of these findings is that we will need more similar studies in the future. So this ends my presentation. Thank you.
Thank you very much. Any questions from the audience? You alluded to the experience of the surgeon. Could you tell us who used the stapler, and did they switch from double to triple during a time frame, and they switched exclusively to the triple? And could that mean that there was a learning curve, and that the better you got, the less likelihood you were to have a leak or a complication? What can you try to expand on that?
Yeah, thank you. The study have a span of about 10 years. So the triple row staplers was available in the recent 5 years. So before that 5 years, all of the anastomosis were fashioned by double row staplers. And with the availability of new stapler, and it was the surgeon's own personal preference to choose whether they want to use double row or triple row. There was initially a learning curve, but given the findings of this study, throughout the period of the learning curve, or even afterwards, the morbidity of the triple row staplers remains very low. And given these findings, also there was later on there were surgeons switched from double row to triple row staplers towards the end of the study period.
Could you clarify something? Because I'm really surprised, because all Europe have to go to Hong Kong, because in Europe, the numbers in leaks and hemorrhage is something 5 times more, 6 times more than we have. You clarify if you are matched versus non-matched patients, you have more than 300 cases without any leak? 0%?
Yes, the 0% came to a surprise for me as well. There was 170 cases. There was our observation. I could possibly postulate the reason is that there is a relatively low percentage of patients with emergency surgeries and with obstructed bowel, perforated bowel, etc.
And why you have 6 days length of stay?
That is this is a typical
System.
duration for our patient cohort.
Good.
May I ask one last question, if that's okay with you? I know you compared the GIAs 3 rows versus 2 rows, but is that the standard? I think it's more common here to use TA staple for the common enterotomy site, which probably there's a cost advantage of using that because you're not leaving and throwing out this completely second set, or either it's 2 rows or 3 rows, because that part is being removed anyway. So what's the really purpose using this type of staple as opposed to using a TA-60? Even with the reload, we know that it's less expensive, at least in the United States. So what is your common practice in terms of using TA staplers for a common enterotomy?
Thank you for your question. We don't use the TA for the functional end-to-end anastomosis. There was the practice in our center is to use the same stapler to fashion the anastomosis. We don't want to change the stapler. So the way we apply the stapler might be different from your practice, but then for our practice, it is a standardized way to do it, and we never use the TA to transect the bowel.
谢谢。
Thank you.